again. I'm still here with Azim Latif, Kendra Grubb, Ole de Bakker, and now also together with Philippe Leurts from the University Medical Center in Mainz. In the next hour, we have two exciting TTVR cases, and we have the pleasure to have Philippe and Ole on the panel to lead us through these procedures that they performed recently. So let's start with Philippe's case. Philippe, over to you for the case introduction.
Thank you very much. Let me go back to the first slide. Yes. Okay. So the patient we treated is a 67-year-old gentleman who presented at least an MYHA class 3, and sometimes in between also he was even more symptomatic. He had peripheral edema and a quite remarkable history of both aortic and mitral valve mechanical replacement. And at least the mitral valve, the reason for replacement was rheumatic disease with significant stenosis. Also some coronary artery disease, but no need for intervention here. It's known to also have AFib and COPD. His lab results demonstrate some signs of heart failure, and the right heart cath demonstrated there was a bit of increase in PA pressures, but not that much. As you can see here, the echo results overall preserved left ventricular ejection fraction. There was satisfying function of both the mechanical aortic and mitral valve prothesis, but what's most relevant is the fact that he presented at that time with significant TR, and using a 5-grade grading scheme, the TR was graded as torrential. Obviously, with previous cardiac surgery, there was also some increased risk in that patient for another surgical procedure. Here you can see the echocardiographic findings on TOE, and what's quite remarkable is the fact not only that there is torrential TR, but also what you can appreciate is that there is limited leaflet mobility, as you would expect from a rheumatic disease, and this becomes more clear when looking at these esophageal X-plane views with typical signs of rheumatic tricuspid valve disease. So far to the characteristics of the patient. Do you have any questions or points to discuss?
Well, first of all, I think it is important to try to avoid treatment futility, and I'm always reassured if patients have preserved kidney function. Are there some patients that by default you would not treat with a tricuspid therapy, Azim? Is there like a patient, is there some entity that you would say, no, this is beyond repair? Is it pulmonary hypertension? Is it RV dysfunction? Is it kidney function? What is your algorithm?
Yeah, no, I think that's a great question, because as these therapies become available and you create a tricuspid program, you're going to be surprised by some of the patients you're going to be sent who, have had TR for many years and now they're resistant to diuretics, and the referring cardiologist or referring physician wants you to treat them. There are a number of factors I look at. If I had to probably start, the most important ones that would push me away from treating a patient would be severe RV dysfunction. I worry about severe RV dysfunction, whether it's repair or replacement. I try and stay away from those patients. Severe pulmonary hypertension, when it's mostly pre-capillary pulmonary hypertension. I also am very concerned that if I treat the TR, I'm not going to make them any better. They're still going to have severe pulmonary hypertension, and they're going to have recurrence of their TR. I think also if the LVEF is too low, I wonder then how much treating the TR is actually going to help that patient, because they have such advanced left-sided disease. So like a patient with an LVEF of 20%, right? And then I think advanced liver disease is the other one I struggle with and I get concerned about. They're at high risk of bleeding. they, putting a TE probe down, maybe they've got cirrhosis or varices, they just tend to do very well. When it comes to renal function, interestingly, we've treated patients with GFRs even below 30, not with replacement, but mostly with repair. And we've had good outcomes. And we've had some patients even where their renal function improves a bit because you're decreasing the venous renal congestion. So I sit a little bit on the fence with that one and will, choose each patient individually. But I still think in the end, Nicholas, we're still learning. These therapies are still in a very early phase. And so rather than making sort of rules about who we treat, who we don't treat, we got to try and be individual about every patient and share what we learn in sort of large, post-market series.
But at the same time, Kendra, I guess the threshold for these patients is much higher to consider open heart surgery, right?
Definitely. This patient, we don't have an STS score for a tricuspid intervention, but this is a high-risk patient with 2 valves, a redo operation, severe TR. I think that, trying to find an alternative solution for this patient is totally appropriate.
All right, Philip. Let's continue.
Maybe the one thing I would like to add about the discussion of the specific patient risk is the fact that all of these factors, liver function, renal function, RV function, bleeding risk, they all turn out to be predictors of inferior outcome when we compare it to healthier patients. But what we don't have so far is having a control group in these high-risk patients. So they might still benefit, although obviously they are at higher risk than healthier patients. What I would also like to ask the panel is, considering the anatomy we're dealing here with, what's the opinion about repair, considering the fact that the gap is a little bit wider, but maybe even more important, the leaflet mobility is restricted?
Ole, what are your thoughts?
Yeah, I mean, what I see from the echo images here, it doesn't look suitable for TIR, I would say. Indeed, it's an enormous gap. They're restricted. It's a rheumatoid disease. I wouldn't consider this for TIR. No, not at all. I mean, you see there on the right top echo image there, there's no coaptation there. It's a massive gap centrally. So not suitable for TIR.
Azim, any comments?
Yeah, no, I agree. I think, the immobile leaflets, the severe tethering and the gaps, I think make it a very challenging TIR candidate. But also, even if you are able to grasp, which, and we're talking about Philip. Philip can grab any valve and put it together with devices. I think, you'd be worried about higher gradients with TIR therapy, and that would be a concern for me. I wouldn't be able to put as many devices, and I'd be worried that I'm immobilizing this leaflet and causing tricuspid stenosis. So I would favor a replacement in this case.
Yeah, at the same time, I think it's also important for the audience to realize that this type of primary tricuspid disease is not the most common. Obviously, most commonly it is a secondary tricuspid disease, and obviously you have more leaflet mobility and so on. But I agree with the panel, and I agree with Philip that this is not a TIR candidate. If anything, this should be a TTVR.
I'm glad that you agree with what we thought when we saw that case, and this is why indeed we treated that patient by transcatheter tricuspid valve replacement. If you can bring the Life in the Box case up, please, for me.
Hello and welcome here in Mainz, Department of Cardiology, for the very first commercial Evoke implantation. My name is Philipp Lutz, and I'm thrilled to be joined here today by my colleague Stefan von Badeleben and also Franz Marcelli, and the 3 of us who will perform the procedure. Today, as always, we have terrific support from an imaging point of view by Theresa Gössler and Tobias Ruf. We have Mr. Rothgerber, who's taking care of patients' GA, and obviously we do have a lot of support from Edwards here in the room. And without further ado, we will start the procedure.
Okay, so The procedure obviously starts with a puncture of the femoral vein. And the first step is to position the wire safely in the right ventricle, and taking care that the wire is not entangled into any cords, because that would make the subsequent implantation of the valve certainly more difficult. There are different techniques to do that. In that case, we started off with a steerable sheath and then used the safari wire to cross the tricuspid valve. Sometimes that can be difficult to position the wire right into the apex of the RV, and therefore we then at the second step used also a pigtail catheter to facilitate correct position. We also at that point in time have a careful look at the position of papillary muscle to make sure that the wire is exactly where we want it. That can take some time, but it's always worth to invest more time at that point in time, because obviously it will then determine how easy and straightforward the procedure is, or more specific, how straightforward it will be to achieve truly orthogonal orientation of the system in relation to the tricuspid annulus in the two corresponding views on an X-plane view. You can see now that the pigtail catheter is now in a different position, is now deeper right in the apex of the RV, and we like that a little bit more. And then as a next step, the system is then introduced. So we implanted an Evoke, a 48 millimeter Evoke valve in this gentleman. Again, the safari wire is then positioned right where we had the pigtail catheter. Then we would bring up the system 28 friend. What is important to know about the system is that there's a flex option in two directions. So this is called primary flex, which allows bending down towards the tricuspid valve. But there's also another flex option, which is the secondary flex. And that secondary flex allows you to maneuver away from the septum to avoid what's sometimes referred to as the aortic hugger, or in other words, allows you to truly achieve a 90-degree orientation of the system with respect to the tricuspid annulus. The system comes up now, and while advancing, we apply some primary flex on the system, which then allows to steer down and into the tricuspid valve. What's important to realize about the procedure is, and you will see that in a second, everything is very controlled. It's one step after the other. There is no need to rush. There's no in between. There is no time where you might have to fear hemodynamic instability, but there's only one way. You can only go forward. There is not the option to go one step back. Okay, so the system is now positioned across the tricuspid valve. The system is then stabilized in the stabilizer. And at that point, a lot of care is taken to achieve a good orientation of the system in the tricuspid valve. And after that, the capsule is retracted, and thereby the first part of the valve is released. At that point in time, while retracting the capsule, these anchors, as you can appreciate now, they flip over. And as a first step, one tries to have them flipping over about 90 degrees. It is important to have that flip happening at a height where the leaflets can nicely engage on these anchors. So not too deep, otherwise it might be difficult to get up to the valve again, but obviously not too high, otherwise the valve would be above the leaflets, and no secure engagement of the leaflets would be possible. We need a bit of fluoroscopy to clarify the angle and the flip angle of the anchors, but it's mainly echocardiography, or more precisely that MPR, as you can see here. So throughout the procedure, it's mainly MPR. Normally in a deep esophageal view, but it depends a little bit wherever you get good visualization, especially in a patient like this one with 2 mechanical valves. The reconstructed sort of transgastric or all-fast view in the left lower corner, that one allows to appreciate how many anchors are, or what leaflets are positioned on top of the anchors. It is possible to miss 1 anchor, maybe even 2, but ideally these 2 anchors shouldn't be next to each other. The aim is really to have all leaflets being in close relation with these 9 anchors. And as soon as this is appreciated and confirmed, so multiple spins are normally performed, especially at that point in time where we do have some experience, but still some limited experience. We really want to make sure that we have all the leaflets being engaged on the system, and then the capsule can be further retracted, and thereby the anchors, they flip even further. So here we are at the later stage of the procedure. The capsule was further retracted. The anchors are totally flipped. And at that point in time, again, it is important to assure that all leaflets are above the anchor. And if everyone is happy, then the capsule is further retracted, and thereby the atrial portion of the device is released. There is no pacing needed. There is not a single moment where one experiences hemodynamic instability. It's really one step after the other. Everything can be done with a lot of care taken and reassurance that the right steps are performed. The position of the device, either further up or down, can be performed either by the wire, by push and pull, but also within the system itself, there is a bit of travel where the device can be put further into the ventricle or can be brought up further into the vacuum. Now the atrial portion is released, and thereby the full device is released. Obviously, at that point in time, everyone carefully looks at the fluoroscopy and echo. We see no rocking. We see some motion of the valve throughout the cardiac cycle, but overall good stability. And this is the first reassurance. The projection of fluoroscopy is then altered to have that reconfirmation. And then all the steps needed to bring the valve in are then repeated, but in the opposite direction to remove the system. There is already quite good leaflet function, despite the fact that the system is still across the valve, but at the first glance, no paravalvular leak was seen. Obviously, we also have at that point in time a quick look at RV function, but remember that gentleman, he started off with a very much preserved right ventricular function with a TAVI of 20, and here we did see no compromise in right ventricular function, and in fact we also saw an increase in systemic pressures immediately after release and implantation of the valve. And then the next steps are really to remove the system, have a double check on echo, and that's pretty much it. I think we can go back to the discussion while the video is maybe still running. Is that possible?
All right, Philip, that is a very nice demonstration of this new technology, at least for Europe. It has become commercially available and CE marked last year. Just help us out here. So this is a 28 French system, right?
Yes.
Yeah, and so what is your access site management? Do you do it completely percutaneous? Is it with perclose pro styles, or is it a surgical access?
It's a percutaneous approach. And the closure is just by a suture. We don't even use a closure system, a dedicated one. And we had no problems so far.
Yeah,
And
but
not only
then again, if you, sorry, go ahead.
And what I wanted to say is that obviously many of us have a huge experience with the clip system or the Pascal system, which comes at a 22 French size. And there again, we also just use a MC suture with no closure device. And I don't think that the additional 6 French in a femoral vein adds a lot of additional risk.
Yeah. So Azim, how to then explain the relatively high bleeding complication rate in the Triluminate trial? But where did
In Tricentennial with TTVR.
sorry.
Great comment. This to me, when I use it, feels a little bit bigger than using MitraClip. I know it's only 3 French difference, but it certainly in my hands feels bigger. I think it is every French you go higher than MitraClip, you have this risk. I think that's the one issue. I think there's no standardized approach about how you close it. Some people use spur closers. Some people just put a figure of 8 suture. They both have advantages and disadvantages. Even when you put the figure of 8, how long do you leave it for? But I think probably the biggest issue is also these patients get started on heparin a few hours after the procedure because you have a big prosthesis in place. And usually by the next day, you start, they're on full anticoagulation. And I think that's leading to some of the bleeding. When you look at the bleeding, only about half of it is vascular. The other half is non-vascular complications. So I think, these are patients that have liver disease, some hepatic congestion. I think for me, when I decide TTVR versus TIA, one of the most important questions I put in my mind is, can the patient tolerate anticoagulation long term? And maybe even, I don't ask myself only, can they tolerate a DOAC? I ask myself, can they tolerate warfarin, a vitamin K antagonist? Because
so this actually
some
marks a
patients
quite special day.
will get thrombosis on a DOAC. And so you'll have to switch them to warfarin.
Okay. So Philip, is there anything more on the video that we need to see?
No, that's it.
Okay, because I had another question on what is exactly the rate limiting step of this procedure? Is it getting that delivery catheter in the right ventricle? Is it avoiding entanglement, chordal entanglement? Is it the interaction between the anchors and the leaflets? What is the rate limiting step?
I guess it's all about ensuring during every step that you do the right thing as always. And as said, once you're in a position where you aren't happy, it might be difficult to go back. If you release the valve too low, it might be very difficult to get up again. If you start too further up in the atrium, then it can be difficult to get further into the right ventricle. So I don't think that there's no specific step during the procedure which is of particular complexity, but during every step you need to appreciate exactly what you're doing and also understand the interaction between the device and the leaflets. But this is still early days, right? And already now we get faster and faster with these procedures. At the beginning, we had to do multiple spins and reassurance on echo, but now we understand much better and much faster what we are doing. So we are still within a very steep learning curve, I'd say.
Philippe, a small question. What is the point of no return? So you go in, what's the moment you're dedicated, you have to release the valve? When can you pull back, retract?
You cannot bring the anchors back into the system. You always have to deploy the valve. And that's why you have to be sure what you're doing. And that's what I mean. There is no single step which is of particular high complexity, but there's only one direction, which is forward.
Okay.
I might also add, that just for the audience to know that TTVR with this valve is very imaging dependent. All right. You need to have good imaging. Otherwise, you can't do it. I mean, Philip showed you a case with 2 mechanical valves, and yet they had really good imaging. That's not always the case when you have mechanical valves. We've had a case where we did a mechanical valve. It looked great in the beginning, and then suddenly we started releasing the valve, and we couldn't see anything. Fortunately, in the US, we have 3D ICE catheters, and that saved us and got us through the procedure. But you need very good imaging, as good as you do for TIA.
Agreed.
Kendra, any comments on pacing? Do you need pacing for the deployment of the valve? And do you have any precautions in terms of the need for pacemaker after the implant?
So I think that one of the commonalities between all of the transcatheter tricuspid devices is this increased pacemaker rate. And that's a design feature that I think will get better over time. So technique, design, one or the other will probably solve that problem. In terms of pacing during the procedure, he demonstrated a procedure where there was no pacing necessary. And I think that that's going to be kind of the standard for tricuspid replacements.
All right, before we go to the next case, Philip, anything else that you want to add to this procedure?
Maybe one additional comment about the pacing. You don't need pacing during the procedure, but you should have some pacing options in place just in case you have one of these rare instances where patients develop AV block acutely after valve deployment. But then obviously you have multiple options. Either you pace via the wire, or you can also bring a pacer across the valve. Obviously, it shouldn't sit there for too long, but if you need it acutely, then, and that has been done, there's no problem with bringing a pacing wire across the valve. And then the permanent option would then either be a micro or a coronary sinus lead.
Yeah. And what is a typical duration of hospital stay? Is it just 1 or 2 days, or is it more a week? Or how is your practice?
Yeah, it's a couple of days. We keep them at that point in time for 2 days on intensive care ward, because we obviously would like to see whether any conduction disorders develop, and there is still a bit to learn for us. Most of them develop very early, which is reassuring. But as said, we are still within early in our learning. So the average hospital stay is about 5 days.
Okay. All right. With that, let's move to Copenhagen for now a different platform for TTVR, the Lux valve. Ole, over to you.
Yes, thank you. Indeed. So indeed, it's a very different platform. Maybe before we start immediately, I see the video is ready. Could we show the slides of the presentation of the patients? That would be nice. Because what I want to do is to go, not to show you too many echo images, but more that also to show you that CT is actually, I love CT, and that CT is really important also in the pre-procedural planning of this case. So very quick, the case presentation. This is a 81-year-old female, arterial hypertension. And as Nicolas said, indeed, the majority of all these cases are secondary atrial because of long-standing atrial fibrillation, annular dilatation, and these patients get then a very symptomatic severe tricuspid regurgitation, so secondary to their long-standing atrial fibrillation. Then to the next slide. Yes, so on echo, I won't show you too much of that. Ejection fraction 55%, a mild aortic regurgitation, a severe to torrential tricuspid regurgitation, pulmonary arterial systolic pressure 50 millimeters mercury, TAPS, so good right ventricular function, which is important indeed, atrial fibrillation, a good renal function, and also what is needed in the screening, because these patients are treated in a trial, the Trinity trial, so there is a necessity that the liver values are actually are still good. Yes, and then I don't have too many images of the echo, but there's a severe to torrential regurgitation. And then the CT, which is really important, first of all, for the sizing. So for the annulus of the tricuspid valve, here you see the minimum and the maximum diameter is important, the perimeter-derived mean diameter, maximum diameter of around 56 millimeter. A small difference with the Lux valve, because this is then specifically about Lux valve and Evoke, is that the Lux valve has valves up to 65 millimeters. So they can even accept really large annuli. And I would say only 1 or 2 patients have ever been screen failures. All the other cases were actually approved. So the screen failure rate is relatively low, which is a good thing. Then next, what you also specifically for this device, then what is measured on the CT is also the distance from the tricuspid valve annulus to the roof of the atrium, so that you have space enough. That's the distance from the TV plane to the free wall of the right atrium is around 8 centimeters, which is more than large enough. The distance from the tricuspid valve plane to the free wall of the right ventricle, there we also need at least 5 centimeter, and that's also around 8 centimeter in this patient, so there's no problem there. Then what we also measure is, because this case is done transjugulally through the jugular vein, not as evoked by the femoral vein. So we also look at the angle coming from the jugular vein, and to come coaxial with perpendicular with the tricuspid valve plane, is the angle 103 degrees, which is also good. If it's too sharp angle, it may also be a problem, because there's a limit on how much you can bend the system, but there are all kind of tricks still. We've had a couple of cases where we had close to 90 degrees and still it's doable. And then the next, what we do is, just like in TAVI, we calculate the S-curve of the tricuspid valve annulus plane. And then the 2 angles we're specifically for this device interested in is, first, the angle where we see the tricuspid annulus plane in line. And of course, that's throughout the whole S-curve, but in an ariocaudal projection. And then the other one on the right-hand side is actually a view where we do not look at the tricuspid valve annulus, but where we look straight on the interventricular septum. So we have the interventricular septum being vertically, so we look perpendicular on this IVS, interventricular septum. And that's important at the end when we go anchoring the tongue, the septal tongue into the IVS, then we use this particular fluoroscopic angle. So here, this is a simulated Lux valve to show you. So it's a valve which has 2 grippers, which typically grip the lateral side, the anterior leaflet. Then you have an atrial brim or an atrial skirt, and then you have this kind of septal tongue, which will be with an anchor, be anchored into the interventricular septum as a last step. The last 2 measurements on CT, what you do is you also measure the angle between the tricuspid valve annulus and the interventricular septum. You want to know how much this angle is, and this is a favorable angle of around, typically it's in most of the cases, around 75 degrees. And then also this angle, that's when the patient is indeed in his laying on his back in a supine position. Then you calculate how much the angle will be of the interventricular septum. And that actually corresponds very nicely typically with your projection, your REO projection also. And that's also important how you introduce the Lux valve system, so that when you open up the system and the septal tongue comes out, that you're immediately in plane, parallel in plane with the interventricular septum. So also this angle you kind of use. So that's the pre-procedural planning on CT. Also on the CT we include, that's just for the study, that the jugular vein is large enough. So this case was good for, of course, it's a done procedure in general anesthesia. Maybe by time, if you can do it with just 3D eyes, you could do it in local anesthesia, who knows? But for now, not the case. It's a venous transjugular access, 34 French, percutaneous access. It was good for an 30-60 millimeter Lux valve plus system. And then, of course, TEE guidance. But as you see during the case, I want to show you in the next 15 to 20 minutes, we also use CT fluoro and ICE guidance. So that's the setup of this case. So I don't know if there's any questions at this moment, or if we go straight into the case. We can play the movie, but in the meantime, I'm open. We can let the recorded case play in the background, and I'm open to any questions and give narration and talk through this case otherwise. So Nicholas, do you have any questions?
It's very, yeah, I think it's clear that your pre-procedural planning is very important. So you should not dive into this procedure without a meticulous CT assessment. Is this assessment for the time being done internally, or do you outsource that to the company? How does that work?
Yeah, this is for now, well, both, to be honest. So the company comes with it. Well, it's triple. I mean, the company comes with it, Jansker. We do it internally as well with our usual Trimencio, where we have the tricuspid package also for, and we also give it to Materialize, which gives us some additional information too. So we're also exploring still a little bit because we have limited experience. It's not that is a routine weekly procedure. So we're trying to find out what is giving us the best information, what can we learn from which analysis. So we're using these three, but it is by time for sure doable to do this in-house, this CT. It's not rocket science. It's doable. Everybody can align the tricuspid valve annulus, make the S-curve, determine these angles. It's nothing. It's not rocket science, as I say. No.
Yeah, and you're not working obviously in the groin area. You're now working in the jugular vein. What is your typical access strategy for this 34 French system? Is it also completely percutaneous, or do you need surgical access?
No, we did from in the beginning, the first case, fully percutaneous, 2 ProGlides, and it works out fine. We never had any issue. Only in one case, I had to supplement with a third ProGlide at the end. But otherwise, we had always nice closure and no hematomas so far. So no, it's definitely manageable, purely percutaneous. Yeah.
Okay, good.
Okay. So let's go large in the video maybe, and we can, because this first 2 minutes is not the most exciting. Let's get because it's just the access, but let's get the video on and let it play. Can we do this? So because here you see we're standing, of course, then indeed on the cranial side of the patient. So let's get the movie large, make the movie large, and let recorded case play if possible. I can otherwise already talk. So we do echo-guided puncture. We do a 6 French sheet. We do the 2 ProLights. So you can let the movie play, please. We do the 2 ProLights. And then after that, there's a set of dilators into the kit. So we up-dilate. Typically, I go 18 French sheet. Then we upscale. So yeah, it would be good if the video would play because the video takes 15, 16 minutes. You see here already that this is after the ProGlides, that now, in fact, there's a safari wire being placed in the right ventricle. I saw how meticulous Philippe was doing this to avoid to be entangled in the chordae coming for the evoke. To be honest, this is not something I've been, maybe wrongly, but I have not been doing so much, having attention for doing the cases with the Lux valve. Maybe it's also less needed because there's a moment where you retract actually the stiff wire. So as soon as the system is just across the tip of the Lux valve system is across the tricuspid valve, you retract the stiff guide wire and you don't have a wire anymore in the right ventricle. So it would be really needed to play the movie now. Otherwise, we will have a problem seeing the entire video, I think.
Yeah, can we get some feedback here?
So, Nicholas.
So you mentioned sorry, go ahead.
Yeah, I was just saying, before I did these Lux valve cases myself, I was very sort of against transjugular access because here we go. Here's the video. I'll tell you my opinion later. Let's get the video going.
No, please do, because the first 2-3 minutes is only about access. So please do, Azim.
Yeah, I was very reluctant because us interventional cardiologists, we like to be at the groin. I was worried about radiation. I was worried about, the ergonomics. But this system is so easy to deploy from the jugular that I'm not sure I wanted to deploy it from the femoral. And also by going jugular, you take away that, from femoral, there's always the IVC, tricuspid annulus offset. It's less so from the jugular. And then the last thing is because you're so close, your movements are so easily transmitted that it's like minor movements and you get the system into place. So I was very impressed.
Yeah, I agree.
So Azim, is this, are you saying that the jugular access might become the preferred access for TTVR?
With some valves, I think so. I think, Evoke, what Philip showed is a very advanced delivery system where you can bend in two directions, right? If you as a company can't do the same thing, allow us to get off the septum from the femoral, then you have a problem. Then you might as well be jugular and not go transfemoral.
Yeah. So maybe we can get the video large because now this is a good moment. So we have done the access. We've positioned the stabilizer. As you see, it's a construction which is attached to the table. And now the valve comes in. So the system, the Lux Valve Plus system comes in. And to be honest, I look in my lab to fluoro where there's CT fused on it. So I just fused the tricuspid valve annulus, which I continuously see on my fluoro. So it's very easy to assess when I'm crossing my tricuspid valve annulus with the system. And here, what I do is actually I go in. This is all very controlled maneuver. It's not that I have the catheter right bare in my hand. No, this is on the positioner. And I just turn a knob to go forward, to go deeper in, or to flex. So that's what I'm doing. I'm flexing the system and I'm pushing forward the system. So you see that here. So what I'm doing here, now I'm connecting to the stabilizer, and then you see the delivery system there. So the blue knob with my left hand, I'm gonna flex, and with my right hand, I'm gonna go forward with the valve. You see that? So I'm moving forward and flexing, and this can go very quick. It's a matter of 2-3 minutes. I look even not on my echo. I just look to my fluoro CT, fused CT image on my fluoro, and I'm crossing. At this moment, I'm across the tricuspid valve annulus, and I'm actually gonna retract the Safari wire already. I think maybe I integrated one of my fusion images here to show you. It's not captured on this live in a box, but I think I'll try to squeeze it into this recorded case. So here we can also see on echo, you see this is the classical view on the right hand side of the echo view. What we want is that the system is roughly 4 centimeters into the right ventricle. Yes, so we have to be 4 centimeters in. And why is this? Because if we're 4 centimeters in and then we retract the sheet, then the two grippers, they call it also rabbit ears, the two grippers will open up. Yes. So now I'm happy. I'm through the tricuspid valve. So now my colleague is retracting the Safari wire. Here you see, this is the fused image. So this is exactly what I mean. So you see nicely the two grippers already ready, these two radiopaque parts. You can see also I'm deep enough into the RV, maybe slightly a bit deeper still. So I'm flexing here and going a bit deeper, more posterior with the valve, as you see. Also, you can really nicely go for coaxiality. So this CT fusion imaging is really brilliant. I think it adds something to this procedure to really judge that you're going really coaxial to the tricuspid valve annulus. So now I'm good. So now I'm retracting the sheet. Yes. So I'm doing this now with my left hand. I'm retracting the sheet in the left upper corner. You see that. So now I do this very slowly, and then these two rabbit ears, as they call it, or these two grippers will open up, and I stop when I have a 90-degree angle of these two grippers. Yes. And these two grippers, of course, they will be positioned at the lateral side, so they have to grasp the anterior leaflet. Very often, this means they are just riding over the papillary muscle of the anterior leaflet. So one of the grippers is on one side, posterior side, the other more on the anterior and posterior side, and you're just catching this anterior leaflet. So that's what I'm seeing there. So now these two grippers are 90 degrees open. I think I will show you also here. Yes, indeed. This is a recording then of the CT fusion fluoro imaging. So here I'm retracting the sheet, as you see, slowly. Takes half a minute. I'm retracting, and now these two grippers, they will start to come out of the sheet, and they will start to have a 90-degree angle. So this is something you do very controlled and slowly. So we're continuing here. And here you also appreciate, again, your very nice coaxial to the tricuspid valve annulus based on your CT fusion imaging. So I think in this procedure, definitely it adds something, this CT fusion fluoro fusion imaging. So here we stop now, the grippers are open, and then it's a matter of checking on your echo. We have to double check the leaflet grippers, whether they're both below the anterior leaflet. This is a critical moment. We do this on the echo, we take our time for this. What is very different for this procedure as compared to the Evoke? Evoke, I would say, is more advanced echo imaging you need. You're very depending on the MPR, the multiplane reconstruction imaging on TEE, which is not every imager who can do this. I would say this we never used with any of the Lux valve cases, so you do not need to use the more advanced MPR imaging. This is very often just the X-plane, what we use. So here we see it's a more transgastric view, and we already see very nicely the two grippers below the anterior leaflet. In one or two cases where we were really having trouble or doubting, or we wanted to be more than 100% sure that the grippers were really below the leaflets, then we actually introduced our ICE catheter, and then you see immediately with your ICE catheter whether your leaflet is on top of your grippers, yes or no. So ICE can also, in some situations, give you extra safety or security. Here you see, for example, on the right-hand side, on the right-hand view, you see on the lateral side, one of the leaflets is very nice on the grippers, as you can see that. So if you see that, then it's you have to check, of course, both grippers, because this is a critical moment, because after this, when your two grippers are indeed below your anterior leaflet, you will expand your entire valve. And this expansion goes rather quick. You do this not slow, but typically within 10-15 seconds, you expand the entire valve. So you have to be sure about your grasping of the leaflets. That's why we take the time also here for the echo. And if we doubt, we will go for ICE to double check that we are really catching these leaflets. So I think I'll let it play. Otherwise, maybe the video we will not jump into the video. Otherwise, it maybe get blocked again. And you see, this is all on X-plane. So we have our X-plane view, and then there on the right-hand side, you see indeed the lateral side, the anterior leaflet, it's on the grippers. Of course, on the septal side, you do not see any grippers. Here, this is the ICE. What we introduce here, for example, this is one of the cases where we did it. So here immediately the ICE, this is 4D ICE, 3D ICE. Here you see very nicely the two rabbit ears, the two grippers just below the leaflets. So we're good to go. Yes, it's in fact, within a couple of seconds, you get confirmation by your ICE. And then we go for the expansion of the valve. And this is, as said, a rather quick maneuver. So this is not something we do very slow. When we go for the expansion, we go immediately for the full expansion. And also at the atrial side, the skirt will come out. So we fully expand the valve. Yes. So it takes indeed 10 to 15 seconds. Now the full valve is expanded. Now it's the moment to check whether our valve is really nicely positioned. So both, is the height of the valve good? We can go a little bit back into the atrium or go a bit more back into the ventricle. We can adjust this. And then also, is there PVL? Do we see a PVL at the posterior end, for example? Well, then we just go a little bit deeper in with the valve. We push it a bit more to the posterior side. If we see PVL from the septal side, we just clockwise turn our delivery catheter to push it a bit more septal. So you really take your time for echo assessment to see whether your valve is good positioned, and you can make these fine adjustments to plug the PVL if there is somewhere PVL, and to centralize your valve really nicely. And if you've done this, then there's only one step further to go. So here now you see my echo colleague, my imager, is checking whether the valve is sitting good. Maybe he's pointing out to maybe a small remaining, well, I hardly see anything, but maybe small septal PVL there. Then you will clockwise turn the catheter, and so you push the device a little bit more septal. And now, if the valve is a good position, this is typically also only taking roughly 5 minutes. And then it's the moment for the septal anchor. So septal anchor, this is done with the deep transgastric views. So you see here, this is deep transgastric view. And then it's, yeah, here you see, for example, nicely the septal tongue. What you want is, what is very critical is that this anchor is during the whole cardiac cycle in contact with the interventricular septum. So that means that during the cardiac cycle, it's not bouncing on top of the interventricular septum, because when you bring out your final anchor, and you would do this on the moment that the septal tongue is not in contact with the IVS, interventricular septum, then of course you miss and you would not have a proper anchoring. So on TE here you can nicely see now this very echo dense part here from roughly 1 centimeter. That's that septal tongue. So this looks nicely in contact, I would say. What I do now for the last 4 cases I did systematically. Before I start my procedure, I actually do a transseptal puncture. And leave a 10 French arrow sheet in my left atrium. I do my other maneuvers of my case, which takes 20-25 minutes. And then when I'm at this stage, I go in just with an ICE catheter, a 2D ICE catheter. I flex it, I put it in the left ventricle. And then you saw these amazing images as you just saw half a minute ago, where you look onto your interventricular septum, and then you see very, very nice this septal tongue on your IVS. And if you see it's bouncing on the IVS, then you know you have to torque your catheter and push it a little bit more into the septum. So now here, this is also an important step. Now this part here at the end of the catheter, this is where we bring the needle shaft. There's a needle shaft, we bring it down. And here, this is that ICE image. So you see very nice, this septal tongue being pushed into the interventricular septum during the whole cardiac cycle, confirmed on TEE as well. So then it's the final thing. Then, in fact, we just have to push out the anchor, which will be done here with the thumb. So, and then you're done. So your valve is in position. So I'll push the anchor out. You won't see it here now. It's too small, but I enlarged the fluoro image and I encircled it here. So here, if you keep an eye on it, so now the needle holder is in place at the septal tongue. And here now the anchor is out. You see maybe an anchor of three wires kind of, which have come out and I've penetrated the interventricular septum. And like this, the valve is anchored. So now it's just a matter, I think we can go back to the panel. So now it's just a matter of retrieving the valve out, which you have to do with care, of course. And then we close it percutaneously and then we're done. I think we let this play in the background. At the end, there's still a nice 4D ICE image of the implanted valve, where you see a nice image, echo image, 3D ICE image. And also in all the cases we've done so far, we had actually no central leak and only maximally a trace PVL. So the results of PVL are really outstanding so far in our experience, limited experience, but experience we have so far.
Wow, it's amazing how controlled. It's multi-steps, but it's very controlled. And at least that I have the impression that it's quite hemodynamically a very stable procedure. Is that correct?
Yeah, absolutely. These patients for anesthesia side, in the beginning, first case we were doing anesthesia was like, what should I look at? I didn't know myself what, but to be honest, it's extremely stable. These patients, typically nothing happens hemodynamically. We also don't need pacing, as you said. We haven't had any pacers also in all the cases we have done so far. I don't know worldwide in all the Lux valve cases, but it could be that the pacemaker rate is very low with this device, because on the septal side, it's only deeper into the ventricle that you have a septal anchor. You're otherwise avoiding pressure on the AV node. So we have been lucky, or we haven't had any pacers so far.
Philip, how does this compare to the EVOC? If you look at this procedure now and compare it to what you did.
Yeah, I wonder, you said that you need less advanced imaging, and then you showed us these quite advanced, beautiful ICE imaging showing the position of the septal anchor, which obviously is extremely comfortable if you have that sort of visualization. But I guess that's not necessarily a must, or is it?
No. It's not a must. No, it's a good comment, Philip. It's indeed, I added it now. I was doubting whether I would add it, but to be honest, I made it standard now in my procedure that I do it. But indeed, normally it's not supposed to, you do not need ice. Yes, normally it's supposed, you can only do this with TE imaging, and indeed only with X-plane. MPR is not a necessity. Yes, it's so, of course, I like to work with ice. I use it for multiple procedures, my LA closures, PFO closure, etc. So it's easy for me, or I have experience with it and I like it. So, but especially for the anchoring part, it gives me an extra level of being sure of my final act. My anchoring is going to be perfect. So it gives me that extra level of security, I would say.
Kendra, any comments from your end when you compare these two procedures? Not asking for a preference for each one of them, but do you see that these procedures will evolve into our clinical practice?
So just, I don't want to interrupt, but now in the background you see the 3D eyes image, yes? So it's from the end result. But please, Kendra, I didn't want to interrupt.
Oh, no, I mean, I think you very elegantly demonstrated what we're going to see as a future with both cases. Just adding more options for patients. This entire procedure you did in about 15 minutes, which is really impressive. And your result there looks, incredible. And so the question is still durability and safety for these patients and patient selection. But I do think that what you're seeing here with these two demonstrations is really way that the transcatheter tricuspid technology, you're setting a new bar. There's going to be a standard.
I agree. Any final remarks from you, Azim?
Yeah, I think we saw two great technologies, and we have to get away a little bit from trying to compare them too much, because I think they very different. With transfemoral, we've had patients rejected for transfemoral evoke because the ventricle is not large enough, because there's cords that are high up, or purpura muscles that are high up, or because the annulus is too large, or because the delivery system is going to end up too deep into the ventricle, right? And they patients who can't undergo TIA, and so we need another option. So I think we're going to end up with a couple of valve options so that we can treat the array of complexity of patients we see. I think for me, this technology is different. You don't need as much space in the ventricle. I like the fact that you can treat larger annuli, and the pacemaker rate is probably going to be very low because it doesn't have as much radial force. But I'm sure there are going to be other issues that we learn as we do more of these cases. So I think the fact that we do clinical studies and collect the data is important. The Trinity study, which is in Europe, will have enrolled almost 100 patients. We've done compassionate use cases in the United States, and we're looking now to start in the early feasibility study.
All right, with that, I think we are on top of the hour. I would like to thank Kendra, Azim, Ole and Philip for their participation in this session. I think these were two thrilling recorded transcatheter tricuspid replacement cases. I think this really is a glimpse in the near future, but it's already reality. So it's very important that we show and demonstrate what is possible even today for tricuspid valve replacement. With that, I think we are coming to the end of this big session on atrial ventricular valve transcatheter therapies. Again, we focused on what would be our goals for MR and TR reduction. We discussed TIR and TMVR and TTVR, and then we ended up with two fantastic demonstrations of transcatheter tricuspid valve replacement. With that, I think we can switch now to the symposium, and this symposium will be hosted again by Darren Mylotte, who will discuss lifetime management after transcatheter aortic valve replacement. This is for the next hour, and after that, stay tuned for more content as we will dive into two sessions focused on revalving for transcatheter heart valve failure. So keep watching for insights you don't want to miss.